So good afternoon, everyone. Thank you for joining. This is the Florida Medical Directors Association, a Society for Post-Acute and Long-Term Care Journal Club, special edition. We are going to talk about the opportunities and challenges of treating COVID-19 residents at place. I would ask that anyone who's joining the call place yourself on mute. You should automatically be muted, but just in case, this meeting will be recorded just so that you are aware and will be available at our website. So today I want to go through a couple of items for our agenda. I want to start with the COVID-19 status update, and then we want to go into the meat of our presentation, which is managing the COVID-19 patient in the SNF and long-term care setting. We also want to speak to post-acute long-term care preparedness. And then we have Dr. Healy on the phone to share with us some tales of a SNF outbreak in New Rochelle, after which we'll have time for questions and comments during our open discussion. So just for the state of the state, you can see that we are now seeing cases heavily throughout every one of our states and in a few of our territories. There are a few territories that are reporting no cases, but what we're seeing is that there are widespread large amounts of transmission of COVID-19 throughout the United States, as well as globally, as we all are aware. This is a snapshot of what is happening in Florida. This was updated last at 6:30 p.m. Yesterday evening. And as you can see, we are now with many more total cases. We are seeing, I believe, over 50,000 tests being conducted, and of those tests, 6,700, over 6,700 people were identified as positive. I wanted to also share with you some information from the COVID-19 Health Data Organization. This is really about projection. So this is the United States as a whole, and it shows that there we'll see a peak in our resource use by April 15th, which means that we are going to, at that point, need over 30,000 ICU beds, 26,000 ventilators, and total beds over 200,000 total hospital beds. When we think about Florida, we're going to see a peak of our resource use by May 2nd, putting us at a need for over 2,600 ICU beds and over 17,000 beds in the hospital and over 2,000 ventilators. So when we're looking at what we need to do, we want to really speak to how do we manage those COVID-19 suspected and as well as positive patients in the SNF. And before we go into the details, I wanted to just alert you to the fact that we did get emergency authorization to use the anti-malaria drugs, hydroxychloroquine and chloroquine, which I may be butchering the names, but we're familiar with Plaquenil. That emergency authorization is in use. It is for patients who are COVID-19 positive. We were able, thanks to Dr. Tafur, to get some of the treatment guidelines out of one of our larger healthcare systems, the University of Florida, which really identifies how we look and group these patients and what potential therapy would be best. So we see that for mild disease that's not requiring hospitalization, usually we're going to deliver supportive care. Where they're recommending to start empiric antibiotics are for those moderate disease states where the patient may be hospitalized or have radiographic evidence of pneumonia. The recommendation is to use hydroxychloroquine, 400 milligrams PO every 12 hours times 2 doses, then 12 hours later start 200 milligrams every 12 hours for 5 days. There is some variation in what we're going to see and what's been recommended for some of the treatment protocols, so I want to make sure and bring your attention to that. They also have recommendations around severe disease with respiratory failure. And some other things that I wanted to include is just some guidance around other possible therapies. We do know that Tamiflu is not a recommended therapy, and we were able to talk about lopinavir, ritonavir last week on our call, and we saw that that also showed a lack of benefit. So when we're looking at the COVID-19 patients, it's really the two scenarios that that I want to discuss. The suspected COVID-19 patient who is currently in the SNF, and I remind you, if you're not talking, please go on mute. And then the COVID-19 positive patient who's discharged to the SNF. So we're going to start with treating in place. And I would really like to applaud a lot of the guidance that we've seen. I have seen several, it feels like hundreds of emails about where do we need to start, in our discussion last week about what do we need to do, should we even be transferring these patients out if they have mild symptoms, and having a lot of conversation around that. And I would say that everything is so rapidly moving and so much information, and we're actively creating policy and protocols in real time. So it's interesting, but I think we all agree that the cornerstone to treating in place for this condition, as many other conditions, is advanced care planning. We need to know what the goals of care are. We need to have these end-of-life discussions, and most of the times we've already started having them. I would hope it's part of our everyday conversation with the nursing facilities that we're in, or the ALs that we go to, but it's going to be very important to make sure we have some documented insight as to what the end-of-life plan is for that resident. So we want to know, does the resident or the family want to be hospitalized, or do we have a do not hospitalize? Will the facility honor a do not hospitalize order if we write it down there, and what that means? Like, are we going to have the medications to treat that person in place? Does the patient family want resuscitation, intubation, or do we have a do not resuscitate order on place? Do we have pulse in place for those states out there who are fortunate enough to have a pulse or a MOLST in action? Florida's not one yet, but if we have it, do we have it in place? Do we know what they want? Have we reviewed it? Are we up to date? And what I've always told all of anyone who's ever had the pleasure of or horror of working with me, we have to have contingency planning. We need to know what we're going to do if the condition worsens, if the symptoms become worse, if we need to do something. So we need to have that laid out, whether it is in your treatment plan and your assessment plan. You need to say, okay, what do I need to do? Because if it's midnight and I have someone who's declining, I want to know what my action plan is. And then, as I mentioned earlier, we need to plan for symptom management. You need to know what your facilities have available, especially when it comes to that 2 a.m., 3 a.m. phone call. You need to know what's available, what's in stock. Whether you're the medical director or an attending clinician in the building, you should know exactly what's in that emergency kit. If you need to order certain medications on hand, we need to know that in advance. And all that comes and gets wrapped up under advanced care planning. It is really the cornerstone to treating multitude of conditions in place. But when we're thinking about COVID-19, we really need to have clear directives about what we need to do with these patients. Then there have been some circulating emails around proposals for treatment, proposals for guidelines for what we need to have placed, and a lot of different proposals, algorithms that we've seen. Many of them have been derived from the hospital protocols that we've seen placed. And what I want to share is just one proposal around what we're thinking about as a protocol to treat a resident in place in a long-term care setting, so or in a SNF. So we need to monitor vitals frequently. I've had debates about what frequent vitals mean with nursing facilities in the past. I know that there's a challenge with staffing, but when you're thinking about a case where a person can rapidly deteriorate, you want to know what's happening, what's going on, what do we need to, what are we seeing in their heart rate, oxygen sat, respiratory rate. I would recommend to start with Q4 hours. I know that there are some protocols out there that calling for Q4 hours for certain vitals, like Q2 hours for pulse ox. And it may vary from chain and facility, but we really need to just agree that frequency means more the Q shift. We really need to be able to keep an close eye on these patients. Then when we're looking at supplemental oxygen, we need to be aggressive in oxygenation, starting them on O2 sat less than 92%, they need to be placed on oxygen. And then starting treatments with hydroxychloroquine and azithromycin as an adjunct is really something that we've seen a lot of cohesion around, a lot of agreement around. I was fortunate enough to be on those email threads, and I saw Dr. Susan Levy and Dr. Jose Pinon, who recommended some protocols. And so this is really a snapshot of many of the elements that they have incorporated. Dr. Ritu and Dr. Swati Guer, I may be butchering her name and I apologize for that. They've also put out a lot of great guidance through AMDA. So like I said, this is something that we're seeing throughout the country that sort of is gaining traction. The EKG, and well, let me go back to the treatment. So when we're looking at plaquenil, you want to start 400 milligrams PO BID for 2 days, and then you could go down to 200 milligrams twice a day for 5 days. The Zithromax pack is something that we're all very familiar with, and that seems to be the treatment that is the most popular and gaining the most traction. You need to have an EKG. This has been met with some controversy, and I know that there are challenges getting EKGs at our facilities. Sometimes that they are done by an external vendor who comes into the facility and performs the EKG. But because of the QT prolongation that we know we can have as a side effect with hydroxychloroquine, we really need to have an EKG before and after starting treatment to monitor for that. And then when we're looking at labs, beyond the COVID-19 testing that I know we don't all have in supply and in stock, you want to make sure you've already screened for the flu. You want to get a CBC, a CMP, a CRP, a LDH, a lactate level, and then some other inflammatory markers, PT and D-dimer. The reason is that we do see that there are elevations in LFTs that are very commonly seen with this condition. We also see lipopenia as the most common finding, although you can see leukocytosis and leukopenia as well. The most common finding has been lymphopenia. And we see elevations in CRP and LDH. There's a recent study that was published in New England Journal of Medicine about severe critically ill patients in the ICU, and they saw elevations in prodromatine and D-dimer as well. And then something that I think that we should also consider and that is really recommended is deprescribing. This was mentioned on our call last week as a way to maybe defer contacts and med passes. But when we're looking at this condition, we really need to think about deprescribing the inhaled corticosteroids, deprescribing nonsteroidals, and the nebulizer treatments. We know we can't do it for all patients across the board. Some patients do require nebulizers, especially if they're trach, they can't get an inhaled meter dose inhaler. They cannot utilize that properly. But when you are giving a nebulizer treatment, if we have a staff member in the facility doing that, they need to have an N95 mask in place. You can use a face shield and a mask. The safest is the N95. And the reason is that the particles, the virus, can stay in the air for 1 to 2, sometimes 3 hours with those nebulizer treatments. So we really have to be very careful when we are giving a nebulized medication in a suspected or COVID positive patient. And of course, we need to isolate all suspected cases, and we're going to talk a little bit more about that in a few minutes. So, like I said before, residents can decline quite rapidly. You may see tachypnea with a respiratory rate greater than 22, 24, with the last check being normal. So you have to really be monitoring that quite frequently. You may see persistent and worsening shortness of breath, increased work of breathing, air hunger, tachycardia or tachyarrhythmias, hypoxia, and severe hypoxia can occur quite rapidly. And as we all know, our population, we may see altered mental status as the only sign and symptom. So we keep an eye on that. Some patients are complaining of headaches, altered sensorium, loss of smell, a lot of different things, but that altered mental status is a sign that the person is declining rapidly. So when we're receiving patients from an acute setting, we do have some guidance around some of these things from our state, but I want to start with what happened recently when we saw that there was a statement that came out of New York State, which said that a nursing home cannot deny readmission or admission solely based on a confirmed or suspected diagnosis of COVID-19. We are very fortunate to have an organization that pushed back very hard, and we were able to get a joint statement with the American Healthcare Association and the National Center for Assisted Living Facilities, which explained that mandatory statement is not in our best interest. We need to really think about how we are preparing and managing this surge and addressing the conflicting guidelines and public policy. We've since then seen statements out of the state of Louisiana that completely took a different approach and said that we're not sending COVID-19 suspected or positive patients back into a nursing facility. So there is a lot of issues and a lot of concerns around that. I'm glad that we were able to put out a statement so quickly after that statement came out on Friday. And when we're looking at what we're doing here in Florida, we've been able to develop a very detailed transfer, hospital to post-acute transfer form, where, you know, it really gives guidance to what we need to have. And I believe these may be, may even go through further updates. We're actually having a call with all the stakeholders in Florida to discuss our preparedness and how do we prepare for the surge. So it may go through more updates, but you know, we're looking at what do we need this, the nursing facilities to know before they receive that patient. So when we're discussing preparedness, you know, there is some good guidance on the CDC's website about what we need to do. And we know that the majority of all of our facilities are doing this, you know, where we have limited visitations. We have reviewed the policies for the staff. In Florida, we are mandating that everyone has a mask and is using PPE when taking care of the residents. We are also looking at, there was some guidance around how do we have people come into the building during this pandemic. And so there was restrictions on volunteers and non-essential healthcare personnel, as well as cancellations of group activities and communal dining, which is a little bit difficult for some of our patients, especially those who may have dementia and other things, they need that socialization. There's recommendations on AMDA's site about what to do with those patients, not to just start them on a antipsychotic, but really to think about, do we need to do videos for them, calling FaceTime with the families and those kind of things. So there's a lot of guidance, I would say, on the CDC site, and we're doing that. But the question that comes to my mind is, what is really the post-acute long-term care continuum? As we all know, it's not just SNFs and long-term cares. There is guidance around what to do at assisted living facilities, and we are seeing in Florida, at least, in South Florida, I would say, I'm not sure about the rest of the state, we're seeing that they're using the same policies in many ALs that have been placed for the SNFs and long-term care facilities. So they're requiring any healthcare provider who's delivering care to their residents to have PPE. They are limiting the visitations, they're limiting activities, and those group activities, the shopping malls and the stores, which they, most of those things are pretty shut down, but quite popular in ALs. But think about how much post-acute care you deliver in your outpatient setting, home care and home health. A lot of people, we don't seem to have a good handle on what's happening from different agencies and different clinicians who are providing home visits. There needs to be some standardization around for those agencies and practices as well. What I have been able to find out and discuss with others is that for those agencies who are sending out care givers, those home health assistants, they now are adopting rules where they need to have on masks and gloves to deliver care as well. And then hospice, we know that there's been there was some pushback on having hospice staff who visit multiple facilities come into our facility. I think we're all in agreement with that. So we need to really think about how we're delivering care in that regard as well. So when we're looking at how we prepare, your facility needs to have a plan to isolate the COVID-19 suspected and confirmed cases, as well as high-risk populations, which dialysis patients come to mind. Unless they're getting dialysis in their room, they're going out to areas where they may be with other people and partaking and being exposed. Most of the dialysis centers have COVID-19 policies that they can share. They're following CDC guidance, but it's still a high-risk population. There's still a lot of modes of exposure there. We have a real issue around protective personalized equipment, personalized protective equipment right now. We know that there's a shortage. We know that there are facilities who are ordering things like mass orders of bandanas. I know for our state in Florida, if you are experiencing a shortage, you can report it to the county emergency management office. I do not know the guidance for other states, but it is imperative that we look that up and we figure out what the plan is, because we need to start reporting these shortages now to prepare for receiving these patients. And then around the medications, a lot of the protocols or the guidelines say to start empirically. We have seen some states put more restrictions on that. I don't know if which states are doing that, but it is really, the restrictions are you have to have a confirmed case. So we got to really think about that. I would recommend talking to your pharmacy consultants and getting some insight from them about what's happening. On our board, we have Rick Foley, who's just been very helpful in answering all of my randomly placed questions to him even on Sunday nights. So we need to get some guidance and some understanding about when can we prescribe. Most of us are in agreement to prescribe empirically, but there needs to be guidance just in case your state is saying that you can. And the states that we did look at those policies from the state boards were Indiana and Ohio. And then the last point that I want to make is about operationalizing telehealth. So, you know, we talked about telehealth last week. We talked about doing telehealth in the facilities, you know, as a recommendation, in which I do strongly support, but you do need to know what your facility is capable of. You need to know how that is going to be operationalized. Who is on the receiving end of your phone call? Is it a nurse? Is it a nurse manager, the director of nursing? Is it the patient themselves, if they have the capability of getting that call, doing FaceTime, using a computer? That's wonderful, whatever modality they can. There's a lot of freedom around it, but how does that really get placed into motion? Someone on our call, the emergency call we have at AMP on Monday night, brought up a great point about being compassionate in this time, because if a nurse is being asked to utilize their phones or to utilize maybe the facility's iPad to do these telehealth visits, we need to be mindful of what they're experiencing as well. You know, we want to make sure we're not overtaxing the staff in this way. So you really need to make a plan with your facility. And if you're the medical director, I would hope you're the leader in developing this plan with your director of nursing and the administrator to really see, okay, how do we operationalize this? Do we want to know the appointment schedule for the docs? You know, what do we need to do, and what do we need to have to put this in place? So I'm hoping that Dr. Healy is on the phone, because I really want her to explain to us what it was like to go through one of these outbreaks. And Ian, Shane, if you see Dr. Healy, maybe we could unmute her line.
Oh, that worked. Can you hear me?
We can hear you.
Oh, good. Well, first of all, I have to commend you on the amount of work that you've done, and you know how well organized this presentation is. I believe that you're all in a far better place than certainly we have been in this environment where we've been very reactive, as distinct from what I'm, you know, appreciating in this call, where you're in a proactive mode. You know, I could tell the long, sad story here. I don't know if that will even help you at this point, but you know, in brief, starting in early March, when we first realized that the first positive case in New York State was right in New Rochelle, you know, that got my attention, that along with the knowledge of the Seattle outbreak. And then I think mostly by tracer, contact tracing, we started seeing more and more so-called cases pop up. And I still, to this day, wonder what, I think we lack an active, a definition, a clinically meaningful definition of a case, and how many people are just colonized versus active disease. So, but in any case, I think through tracer contact, more and more so-called cases were materializing around our facility. And I moved a couple of days before the governor did to institute a non-visitation policy, which was very painful, and it remains so. And basically, I think the whole experience that we had back then was just trying to figure things out. And, you know, I had to dust off and update our pandemic influenza policy, then we operationalized it, and then we, you know, we were off and running from that point on, instituting all of the things that all good facilities either are doing or are about to do in terms of screening. Well, first we had to shut down to visitation, which was a very, very painful experience for all of us. I had to turn people away at the door. 2 days later, Governor Cuomo implemented the non-visitation mandate. So it got a little easier after that. We stopped having so many people angry at us. But to this day, there's basically been no visitation here. It's a different environment in the nursing home. This used to be a place of joy and community, and we're more like sort of an empty barracks, and people, you know, acting and operating like soldiers to some degree, but a very, very different culture and different experience. We did our level best to keep COVID out, so to speak, and as I mentioned, screening staff, screening, you know, stopping all of the vendors or non-essential vendors, all of the things that everybody knows about, asking questions, you know, have you traveled to China, all of this stuff. We had positive cases, and some of them, one long-term unit, and then our post-acute unit, one area in our designated post-acute unit. And around the time that we got those results came the governor's mandate, which I know you all saw. We're a not-for-profit, and our census went down drastically when, you know, obviously with the association with New Rochelle, and we were among the first, again, with the non-visitation policy, and I don't know, just all of a sudden referrals dropped, and our census declined dramatically, and we are on a very razor-thin operating margin. And around, my poor CEO is agonizing over laying people off and everything that they have to deal with on those issues. So when we got the directive from Cuomo, oh, and by the way, you know, of course, we live and die by our post-acute referrals, and the hospitals around here are on their knees now. And between a sense that we had no choice, we had to bring some people in to fill the beds, plus it was mandatory, plus our hospital partners were needed us to do this, if you will. The next thing I knew, we were opening a COVID unit, and we've taken in, I think at this point, about six COVID post-acute patients on that unit. I can at some point get into the details of, you know, the engineering controls and so forth. And then we moved all the people that on the long-term unit where we had the case, we moved them up there. So we've got everybody up there, we think, but we've had isolated, you know, fever spikes and coughs throughout the facility. I strongly suspect it's COVID. Those people are put on contact droplet precautions. We have a lot of private rooms here, thank God. And when we don't, we move the roommate out. I don't know what good all of this is doing. But we're really trying to cohort our suspected or known COVID patients in this one unit, not because, I don't know if it makes sense so much for infection control, but at this point, we're running out of PPE. And so we have a dedicated staff who get one set of PPE per day, even though now we're running out of that. And that's the idea. So if we simply cohort these people, we're going to save on our PPE. The problems, among others, that we're facing is lack of testing materials. Originally, all of New York's tests, and by the way, if I'm talking too much or whatever, you have to cut me off, it's fine. I don't even know what I'm saying anymore. But all of our tests, because we're a nursing home, had to go through the State Department of Health, And, you know, there was a long turnaround time for that. Then the next thing we know, we ran out of testing medium, vial transport medium. And then now we have it, and we're trying to figure out how to get it to a lab. We think we would use our remaining, we have 20 test kits to test the people around the facility that we have on contact droplet precautions to see if they really do have it, in which case we can move them to our designated unit and spare the PPE that's going to waste potentially there. But we're still trying to figure out where to get our tests done at this point. What else can I tell you? We had a supply of N95s that we distributed to our staff that are working up on that unit. We are reusing them. And I can share some of the techniques around that. I don't know how good they are, but I see a lot of better guidance coming out now, but then when we were starting out. And we just got this today, which is a face shield. Literally, we're in the process of giving them out, which is very, very nice. And it's vented on the inside here. And so you're able to, I'm sorry, we have a space from here to the inside. And with our N95s and a surgical mask over them, over the N95s, and whatever PPE we can put on superficially over our clothes, that's what we're doing. I guess we're in better shape than a lot of people. It's
Dr. Healy, I don't know if you were able to show that picture on video, but where you were holding up a mask. I was trying to see if we could project it, but I wasn't able to.
Oh, you want me to do it again? I will send you. This is literally hot off the presses, and I will share with you all of the details where we got it. But I'll try this again. It's with the plastic front, a double. I don't know. I'm trying to look and see if what I'm showing you here. But you can see it's open here to the air, to the surface air. And there it is.
Yeah, do you send me a picture of it? We can put it on our website.
Yeah, I'll send you a picture, and I'll send you these came today. Our director of admissions somehow knew someone who repurposed their factory to do those. I'm told this is better than what they have in the hospitals. So I want to get all that information out.
Yeah, and what I would like to do at this time is just sort of open it up to anyone who may have questions for Dr. Healy or myself or anybody else on the call.
Oh, before you do, one last thing, if I may, is the discontinuation of transmission-based precautions is totally nebulous unless I missed a memo somewhere. The ones that have been released, as I understand it, by the CDC, even by the State Department of Health, they're talking about people that are in home-based quarantine, if you will, and you know, when they can come off, and it's all symptoms-based, which is fine, but we don't know whether we can take our asymptomatic recovering patients and move them off this unit, because we all know they're still shedding, right? There's virus shedding that's going on for weeks. So what do we do with them once they're better? And then do they go directly to home care, or I don't know. I don't even know what's going to happen. That's the other thing. Hospice, just quickly, New York State mandated hospice cannot accept COVID patients, which is shocking. So that's what's happening here. And with that, and we're setting up telehealth even as we speak.
Yeah, you answered my first question for you. But the New York state mandate that hospice cannot accept COVID-19 patients, I'm a little lost on. Do we know what the logic was behind that one?
And when I heard this, it was a week ago, and the logic was more or less home hospice based. In other words, their home aides go to multiple places, and their home health aides. So if they went from a COVID positive home-based patient to another one, they could. That was the logic of it. Beyond that, whether they've changed it, I mean, that was the last time it was about a week ago that I was talking to my hospice provider here, and I went online and I found the mandate from Cuomo. He may have changed it, but I don't think that they can come in anymore. And nor can we discharge people home, I guess, to hospice care. That I may be wrong about that, but that was my understanding as of a week ago.
Okay. Do we have any questions or comments at this time?
Yes. It's my understanding that in Florida, we can still refuse a patient until there's 2 negative tests 24 hours apart from the hospital.
Yeah, that is still my understanding as well.
Wow.
Thank you.
Yeah. If anyone knows anything different, please let us know, but that is still my understanding as well.
That's great. I missed the earlier first 5 minutes of the presentation. Are people having it in their facilities?
So I think we are seeing cases. I don't know where all those facilities are at. Ian, you may know more about this, or someone else maybe speak up. I am not aware of all of the facilities, but I do know that we're seeing transmission, and we've seen a lot of transfers from SNFs to the facilities with suspected cases, at least down here in South Florida.
Well, then you're in good shape in the sense that you have time to prepare. I mean, thank God you don't have to take them, from the post-acute into your post-acute programs. So you will not be dealing with that particular set of issues. And it sounds like you're well prepared. I, heard your protocols and everything as best you can be for an institutional outbreak. That's very good, because, we were just figuring it out on the fly over these last few weeks, and you're way ahead. And I think that's so good for you.
Dr. Healy, I have a question for you. Can you hear me?
Yes.
How many COVID-19 patients did you receive in your facility?
Could you say that again?
How many COVID-19 patients did you have?
Did we have?
Yes.
Okay.
How many have you received?
We had 3 positive, based on tests. We had 3 that were from within our facility, and we've accepted around, I think, 4 or 6, let's say 5, let's split the difference, 5 from the hospital.
Okay, the ones that you accepted, were they 2 negative in 24-hour tests, or you just
Hell no. Hell no. They're sending them, this is what's, sorry, but they're sending them, oh, no way. You know why? Because they may never be negative, let's face it. I think that guidance is going to evaporate. But if you can live under that illusion a little longer in Florida, you should. But they're shedding for who knows for how long, probably for weeks.
Actually, study shows that they shed up to 35 days, and some of the Chinese studies that we have read. My next question was, how was your isolation procedure for these patients, and when did you stop isolation on them?
That's my point exactly. So the first ones we took came with directions to keep testing, telling us, keep them and do serial testing until you get 2 negatives a week apart, something like that. Well, we don't even have the testing kits. So even if that made sense, which I don't think it does, we couldn't do it. So now that's exactly our dilemma. We have 20 patients that are either suspected or confirmed COVID in a designated unit. We don't know when we can take them off precautions. And that's where unless someone knows that there's guidance out there, the only guidance that I've seen and received, and I've been in contact with the county commissioner of health, is they keep sending the ones that are home-based, the people in self-quarantine, and which are symptom-based.
Yeah, the guidance that I saw, the CDC, it said that there had to be resolution of fever without the use of fever-reducing medication, with improvement in respiratory symptoms, and if it was a test-based strategy, they need to have 2 negative nasopharyngeal swabs 24 hours apart. Now, I think the problem is, like you just said, we are seeing variations in that shedding period. Dr. Tafur, you just mentioned 35 days. I saw someone said less, and some said more. And, it is a risk, and we do need more guidance and evidence about what we need to do around that. I definitely agree with that.
I mean, I don't know what to do with these patients that are there. I mean, can they go? Do they have to stay? So it's really baffling. Yes.
Can I ask a question? We have Dr. Reyes on the line. Let me see if he's still with us. Dr. Reyes, are you with us? He's an infectious disease physician. I was wondering if he can help us with those questions.
Yeah, maybe we can.
Oh, he doesn't have a mic.
Do you know his number? Oh, okay.
Okay. He's in his hospital computer. He doesn't have a mic.
What his number?
I asked the infectious disease in our facility about this shedding, and his explanation was that the patients now be shedding up to 35 days, and depends on the study and the article that you read. But it's like having a C. difficile colitis patient. The patient has been transferred, he's already off isolation, still he's going to be having some C. difficile up to 3 months or maybe more too. But still, in this case, the patient could be infective. You have to do a fecal PCR.
Makes sense. But then the staff still needs the PPE.
That's the question.
Right? They still should be on contact, transmission-based precautions.
I'm not sure how long are you going to keep this patient on isolation based on eating.
I wish I knew.
So I know that we've been getting a lot of messages in the chat. Shane or Ian, do you see any questions that we need to point out? I'm trying to open it up now.
And can you hear me? Yes.
Yes.
So first question,
yes,
thanks for sharing your story, Dr. Healy. I'm interested in what kind of PPE burn rates per day you have seen in the COVID-19 unit on a per resident basis.
That's a great question, and I don't have the answer off the top of my head, but I will find that out. You said PPE burden, I believe you said, right? That was the
burn
phrase.
rates.
Burn rate.
Yes, ma'am.
I can find that out, and, because we know how much stock we had, and we know where we are now. So I will definitely let you know.
Thank you. All right, next question. Our facility in Largo, Florida is hesitant to take an RSV plus patient post-hospital. No COVID test was done, CT test was done, and per CT, COVID was ruled out. There's mild lymphonia on labs. Patient now free affable. I understand co-infection is rare. Is this true?
I'm not sure you're asking me.
I'm not aware of that. If anyone knows, I don't have the answer to that either. I'm not aware.
Is COVID prevalent in the community?
Yes, it is. And the question was about RSV, Shane?
The question was, it's RSV positive, patient post-hospital.
Yeah. If you could send that to us, we can maybe ask one of our, you know, the infectious disease docs who we work with and get that answer back to everyone.
I have some more questions from the chat if you'd like to continue.
Yes, please.
I have an issue with some SNFs are refusing providers who have been to other SNFs within the last 2 weeks. Is anyone else seeing this, and is it legal?
You mean medical physician providers, or?
I just have the word providers.
Yeah.
So it can mean nurse practitioners, physician assistants, or physicians. Yeah.
I mean, are you talking lab providers and diagnostic imaging?
Physicians and nurse practitioners.
Clinicians, okay.
Diane, this is Nashira. I think in the paper on the Seattle infections, some of the epidemiological tracing and the rapid spread to other facilities were caregivers who worked in 2 or more facilities. And so I think that's really crucial to limit people to work in whatever facility they're working in. You know, some people might work different shifts. Nurse practitioners, of course, can go to several facilities. And I think that's risky because that's the epidemiological tracing that was found in the Seattle outbreak.
Yeah, I agree with you, Dr. Padilla. I think we have to really think about the way that we're practicing medicine now. It's going to be painful. It's going to be hard, but we're going to have to make certain adjustments because we don't want to be the one carrying this disease from facility to facility. And I'm sorry, I might be getting some feedback, but I'm going to get off the soapbox about it. I know it's really hard, and trust me, I understand the intimate pains of running a private practice or both solo and with multiple practitioners. We just need to think about how we're doing things. That's why I would highly encourage you to get with your facilities, talk through telehealth protocols. You know, how can we do it? What are the hours that you're going to allow this to occur within? You know, create the plan and be part of that creation, because not only because I don't want to see the other healthcare providers falling to this disease. We've already lost some people in Broward County as well as in Miami-Dade, and we don't want to lose any more of our healthcare providers. You know, and we don't want to be the cause of spread.
I should mention that my post-acute physician is out very sick, and 1 nurse practitioner from our ISNP. So that's 30% of the medical staff right there. I think if you can do the things you're doing, you know, you've identified and you're ahead of the curve here, you can really impact on what happens in your state.
Well, thank you. Dr. Healy, we may actually ask you to join our Florida stakeholders call too, because we really want all of our stakeholders to know what is happening. We can send you information about that. To everyone who's on the call, if you have any further questions, please email them to me or Ian, Shane as well, and we will help you get the answers that you are looking for.
Thank you. Good
All
luck.
right. Thank you all. Thank you for joining, guys.
My pleasure.